So as you think about this case, putting together that high-risk clinical feature, some of the high-risk molecular features, and as we talked about, we have a number of different chemotherapy-based options, we have novel agents. What would you think about for treatment of this patient?
So probably the feature that drives my choice of treatment for this patient most is the presence of the mutated TP53. As Nitin was saying, the use of chemoimmunotherapy for those patients is really contraindicated in my mind. We get toxicity with very little clinical benefit from chemoimmunotherapy for these patients. We have a very active drug that's approved in the frontline setting, which is ibrutinib, which would be the treatment of choice, my choice for treatment for this particular patient, with an expectation of good outcome and response to treatment with the ibrutinib monotherapy.
Great. So this patient was in fact started on ibrutinib at 420 milligrams daily, standard dose. And initially the patient did develop some grade 3 neutropenia after about 4 weeks on therapy, but this was managed with some growth factor support and later resolved. They were able to continue dosing at full dose. And the patient's symptoms improved quite dramatically over the course of the first 6 months of therapy. The splenomegaly and hepatomegaly resolved. The pleural effusion did require some initial thoracenteses over the first few months, which is pretty common, but eventually that actually improved as well. And the lymph node size was reduced by about 80%. So about 6 months after starting ibrutinib, the laboratory results looked much better. There was still a lymphocytosis, as is commonly seen at 6 months. Total white count was around 32, but the hemoglobin by that point had already improved to 11.4. Platelets were up to 143, and you can see that the LDH remained normal, and the beta-2 microglobulin had come down. So now we've had this 75-year-old patient on ibrutinib for several months, and it's likely that we've run into some toxicities. We heard a little bit about some neutropenia, but there are other ibrutinib-related toxicities. So maybe Dr. Jain, you could take us through some of the common toxicities and how we might think about them.
Sure. So with ibrutinib, I think one of the things I tell my patients is that there is a common toxicities include loose stools and diarrhea, skin rash, arthralgias, which all of these may be seen in 20 to maybe 40% of the patients. So that's important to point out to the patients. The other toxicities of importance will be hypertension, and certainly patients who are already hypertensive and they're on 1 or 2 hypertensive medications, once they start ibrutinib, it's not uncommon that they have to either increase the dose of the medications or add a third or additional agent. The other less common but more significant would be atrial fibrillation, which is seen in up to 10% of patients. Some studies quote a bit higher number. But again, that's important toxicity to recognize as well as manage, also from the standpoint of anticoagulation. Typically, patients with atrial fibrillation, in our practice, we hold the ibrutinib if it is a first occurrence, and we consult the cardiologist and see if they want to rate control or rhythm control the patient. And then we kind of have input of cardiology team in terms of the anticoagulation for the patient. With respect to anticoagulation, typically Coumadin is contraindicated with the use of ibrutinib, but there are other oral anticoagulation agents, new oral anticoagulant agents which could be used. And for the first episode, we typically restart the patient at the same dose. If it recurs again, then the recommendation would be to go down by one dose level. And the other important aspect with ibrutinib would be bleeding complication. So ibrutinib has some antiplatelet effect. And there have been cases with serious bleeding, including CNS bleeding, have been described. So that's something also to watch for when your patient is on ibrutinib. And on the similar line, there are recommendations for patients undergoing surgical procedures to hold ibrutinib pre and post procedure, which again would be something to recommend to the patient.
Great. I also wanted to ask Dr. Wierda to comment, just because we've seen some somewhat conflicting data sets coming out in terms of what the clinical trials show for ibrutinib toxicities, and then some of these studies of quote-unquote real-world data where we see much higher rates of toxicities. And I'm curious what your perspective is on where the truth lies there.
Well, the truth always lies somewhere in the middle, is a famous old saying that I would go back to. But the clinical trials, as you suggest, the clinical trials are there's a lot of conformity, and there are rules that we need to follow for clinical trials, and patients are very motivated, and so the profile for toxicity although it's collected very diligently, may be somewhat different than what is seen in the community. There are inclusion criteria that we have on our clinical trials, so the fitness of the patients may not be exactly what it is in the community. We know that this disease is most common in people over 70. Those are really usually not the patients who are participating on clinical trials. And if they're over 70 and they're participating on clinical trials, they're usually very motivated, very mobile. They can come to an academic center. So there probably are differences in terms of the patients who are enrolled on clinical trial versus what's the patients who are treated out in the community. So again, I think the truth is somewhere in the middle, and there are concerns that we see in terms of toxicities, et cetera, that need to be certainly considered.